I welcome you all on behalf of Pakistan Endocrine Society on its 19th annual conference. My name is Dr. Sumera Batool, and I am a consultant endocrinologist currently working at Dr. Ziauddin University Hospital, Karachi. I will be moderating this session today. The topic of today's session is Pakistan Endocrine Society and its local research initiatives. Research activities are the need of the hour, and Pakistan Endocrine Society is doing a lot of work to promote and support local research activities. In fact, quality research is included in the main manifesto of Pakistan Endocrine Society. So without further ado, let's start the session. First of all, let me introduce you to our chairs. We have Professor Dr. Zaman Sheikh with us, who needs no introduction. He's one of the founding members of Pakistan Endocrine Society. He's a renowned endocrinologist and director of Sir Syed Institute of Diabetes and Endocrinology. Thank you, sir, for joining us today. Our second chair is Dr. Faisal Masood Qureshi. He's a well-known consultant endocrinologist at Multan. He's an elected president of ACE, an executive member of Pakistan Endocrine Society and South Asian Endocrine Society. Thank you, sir, for joining us today. Moving on to our talks, our first talk is about real-world evidence, Dapagliflozin and Liraglutide in Pakistan societies. And for this, I would like to invite Dr. Umar Yousaf Raja. He's an MRCP UK, FRCP London, and a consultant endocrinologist at Shifa International Hospital, Islamabad. He has various research publications, abstracts, and posters published at national in journals and conferences. Thank you, Dr. Umar, for joining us today. Over to you now.
Assalamu alaikum, everyone. And again, thanks to organizing committee, scientific organizing committee. So the only disclaimer I've got is that scientific draft बनाने में मेरा कोई ताल्लुक नहीं है. So back to back, अपनी presentations मैंने नहीं रखी हुई. I was in the organizing committee. So I'm going to present today on what as on the platform of PES we are doing. So these three talks are actually local data run on the platform of PES on the newer medicine, diabetes medicine that we are using in Pakistan. So I will, so otherwise no other, well, these are the disclosures and this is the overview. So I'm first going to describe about why should we think about real world evidence. I have got a keen interest in real life data, and I think in countries such as our, we need to have more real life data as well. So I'm going to go through the definition and sources, comparison with randomized control trial, benefit and limitation, and then I'm going to present mostly on Dapagliflozin real world evidence, starting with the UK real world evidence and then Pakistani real world evidence, and then a bit about the Liraglutide real world evidence as well. So real world data is the data related to patient health status and delivery of healthcare, which is routinely collected from a variety of sources. And these sources can be your electronic health records, your insurance data, the product and disease registries. And real world evidence is actually the evidence based on this real world data, which is regarding the use of and potential benefit or risk of a medical product derived from analyzing these real world data. And it's provide area information on a diverse area. So such as natural history of the disease, course of disease, effectiveness studies, outcome research, and safety surveillance. So here you can see the sources. So I mean, there can be multiple sources. We tend to use mostly electronic medical records and patient registries, but I mean, you can use sources such as in those countries with the insurance claims database, randomized real life studies, or health surveys. All of them contributed to the sources. So I first need to describe to you about what are the different types of trials that you are going to study about when a new drug came into the market. So of course there are registration trials. So there's a phase 1 trial to look about the proof of concept. The phase 2 trial is mostly about the dosage, what sort of dosage we should be using. And the phase 3 trials are mostly about on a large number of patients to look about the efficacy and also the safety as well. Then there is a pragmatic randomized trial, and our SAFE-Pak study, which is going to come later on, is an example of that. And then there are observational studies, and those observational studies can be either prospective or they can be retrospective as well. And here you can see the comparison. So, I mean, randomized control trial is still gold standard, but their randomized control trial have got its own limitations as well. So here you can see there is an interventional experimental type of study, whereas real world evidence is non-interventional observational. It is based on a strict protocol, based on a good clinical care practice, whereas real world evidence is what we are doing in our day-to-day routine clinical practice. RCT look at the efficacy and safety, whereas real world evidence is actually looking at effectiveness and then economic assessment. The population, of course, because it's strictly driven on the protocol, the strict inclusion, exclusion criteria. So it's a very narrow population with extensive selection criteria. Whereas the real world evidence have got wide, unrestricted population with few exclusion criteria. Real randomized control trial usually have a gold standard or a placebo arm. Real world evidence, there's no comparison, comparator, all usually there's a standard care. And of course, real randomized control trial, there's a randomization and blinding, which is not possible in real world evidence. And the main thing about randomized control trial is that you are going to look at the internal registry, how robust that study is, whereas the real world evidence is actually looking at a clinical practice. So basically, if you look at real randomized control trial, they are very highly focused, fine-tuned sorts of data. And there's a clear sequence of events. So participants are first exposed to an intervention, and then outcomes are observed afterward. But it's very expensive. There's a high cost per patient, and we knew those studies can run in terms of billions of pounds. And it addresses, can it work? Whereas what I'm more focused on in the real world evidence, which is affected by uncontrolled variable with result more applicable to daily life, but it addresses that question outside that artificial setting of a randomized control trial. So it's cheaper and it addresses, okay, does it work in a particular population? So randomized control trial, as mentioned earlier, have got its own limitation because it focuses on gaining internal validity, which may sometimes compromises generalizability. So for example, here you can see, this is, I mean, Scotland have got a very good data, internet data regarding their type 2 diabetes. It's called Scottish Care Information. And you can see that they actually capture 100% of their patients with type 2 diabetes, 180,000 patients. Now, you're all aware of those well-famous trials, Accord, Advance, Proactive, Record, and VAT. If you apply the strict inclusion-exclusion criteria for each of those randomized control trial, only 11% of the Scottish population will fulfill that criteria. 35% for Advance, but look at most of them are around about 10 to 15%, not more than that. Similarly, we all heard about EMPA-REG. Whichever presentation or whichever conference you go, EMPA-REG. But look at the Royal College of General Practitioner database, 60,000 patients. Only 15% of their patients fulfill the EMPA-REG criteria. So if you look strictly on the evidence-based medicine, you can only apply that study on 15% of a UK population. It's much less, I would say, for a Pakistani population because we are all South Asians. Another sort of basically you can see, this is the CWAT trials on the GLP-1 agonist. And again, you can see XR for exenatide weekly, Leader for Liraglutide, Sustain for semaglutide, Remind for duraglutide. And again, 3 of the CWAT studies, if you look at all the US population, only 10 to 15% fulfill that criteria of the normal clinical population that you see. More for the Rewind, around 40%, because they are focusing more on the patient with the high risk group. So that's why there is this trial effect. What you see in the randomized control trial can actually differ from everyday practice due to existence of a rigid study protocol, more frequent follow-up visits, additional support to patient to ensure treatment persistence and adherence, extra time dedicated to patient education, and careful monitoring of efficacy and trial effects. So that's why you see that you will see maybe a very good HbA1c response, okay, in the clinical trials, but real world it might not be, that effect might not be there to a number of other reasons as well, such as inertia. So what about the real world evidence benefit? It provides data with relevance to clinical practice, insight into early and long-term clinical experience, compare effectiveness and health outcome, You can also monitor whether you're compliant with your treatment guidelines or product label. It can identify the suboptimal dose or treatment. And again, it can also identify whether suboptimal dose might be effective in a particular population. So for example, a lot of you people are using dapagliflozin 5 milligram. Dapagliflozin 5 milligram actually is licensed either for type 1, and that's a RICOG, or people who have got hepatic impairment. It's actually a 10 milligram dose. So again, you can find out about how many of your patients are taking 5 milligram dose and will have a good effect as well. Monitoring safety, especially uncommon rare adverse effect. Example is euglycemic diabetic ketoacidosis. That was found in real world studies. Support for expansion indications. So for example, Liraglutide is now licensed to be used in adolescents purely based on the real world studies. Generates hypotheses for prospective trial and evidence to support health outcome and patient acceptability. So basically, you can see that real world evidence assess a wide range of parameters in a broad population of patients. Look at things as safety parameters, psychosocial factors, healthcare utilization, cost effectiveness, treatment persistence, adherence, financial burden of disease, patient reported outcomes, clinical outcomes, and quality of life measures. So challenges, there are challenges. Firstly is validity, because it's an open, unbranded, non-randomized design, which raises question about their validity. The other thing, and the big thing in our setting, is the data quality, because there's a gap in the accuracy, completeness, and quality of data, especially in developing country, and of course, there's a confounding factor as well. So yes, we have to take real-world evidence with a pinch of salt, but it's not saying that randomized control trial is better or real-world evidence is better. It's actually totality of evidence requires studies that complement each other. So you randomized control trial sit in the center, but all of those trials actually feed to that, just to improve your evidence and basically improve your understanding about a particular drug. So to summarize, before I go to my part 2, it's not meant to replace randomized control trial. Randomized control trials still remain gold standard. It's actually meant to complement it, and that's important. And that's why even the major regulatory authorities like FDA have actually now recognized real-world evidence as a source of evidence. So all the new cardiovascular outcome trials are actually based on the real-world evidence. So, okay, with that introduction, let's look at the dapagliflozin. Dapagliflozin, we knew there are three, the commonest SGLT2 inhibitors, dapagliflozin, which was launched first in 2013 in UK, canagliflozin, which was launched first in US, and then empagliflozin, which was launched around in 2015. And if you look at dapagliflozin, here you can see that on average, if you look at the phase 3 trials, you're looking somewhere between 0.6 to 0.8% reduction in HbA1c, whether you're using it as a monotherapy or as an add-on to metformin, or as an add-on to sulfonylurea or to DPP-4 inhibitors, or even an add-on to insulin. One of the first real-world data actually was published in British Journal of Diabetes and Vascular Disease. And here you can see this is a London data around about 79 patients. And you can see that HbA1c reduction was around about 6 months was 0.84% with a weight loss of 2.2 kilogram and a slight sort of basically blood pressure lowering effect of 3.9 millimeter mercury. So ABCD is Association of British Clinical Diabetologists audit. It's a nationwide audit run in UK, run by one of my consultants. I work under him, Bob Ryder. And this is their data, and you look at around 943 patients with mean age of 56, mean duration of diabetes 11.4 years, baseline HbA1c 80 millimoles per mole, all in person rate 9.5%, and a baseline weight of 103 kilogram. So here you can see, when you compare with the phase 3 trial, again, you can see now very nicely that the HbA1c reduction is 0.89%, similar to what you expect in the phase 3 trials, and a weight loss of 2.7 kilogram. So that's actually the real world evidence from the UK that's actually working in the UK population. I mean, I myself have got my own data from 2015. So this is published in JPMA in September. And here we look at 121 patients for HbA1c analysis and 96 patients for weight analysis. And what we found was an HbA1c reduction of around 1%. So it's about 13 millimole per mole, and a weight loss of around 1 kilogram. But surprisingly, and I will come to that later on, look at the UTIs. Only 8 patients have got UTI, 9 patients have got candidiasis. This is UK wide patient data. Dehydration, 5 patient, hypoglycemia, 5 patient. You can see insulin unit coming down from 92 to 81, so about 8 units. And also we were able to find out that if you do the subgroup analysis, the higher the HbA1c, the more HbA1c reduction you will see, and that's pretty much with all the other drugs as well. So you'll see maybe more than 1% where HbA1c more than 9%. Similarly, look at insulin versus non-insulin. Pretty much similar effect, whether in terms of HbA1c reduction, whether they are taking insulin or they are not taking insulin, showing that it works purely as an insulin independent mechanism. So what about Pakistani data? Dapagliflozin was launched in Pakistan in 2017. So far, there are 4 real-world studies, one from Islamabad that I'm going to discuss in detail. Our one was the first one to be published, 2 from Karachi, and 1 from South Punjab. So one is it's a Najim Saab data from Ahmad University, around about 100 patients. Then our one was the first to publish. This was Shifa's and Umar Wahab Diabetes Center. So this is around 412 patients. Then there is Professor Tasneem Ahmed data from Mid-Am Karachi, Single Center. This is a mixed data on EMPA and Dapagliflozin. And then there is a Single Center data from South Punjab, actually from Bahawalpur, 400 patients. So overall, we have got around about 1,000 patient real-world data now published. So when we look at our experience, 412 patients with mean age 52 and mean duration with diabetes 9 years. So their baseline HbA1c you expect it will be high, 9%, baseline weight 87 kilogram. They have got dyslipidemia, around 65% have got dyslipidemia, 50% hypertension, and 11% coronary artery disease. 82% were prescribed dapagliflozin 10 milligram, while 18% were prescribed dapagliflozin 5 milligram. 34% patients were on insulin, 88% on monotherapy, and 11% on dual therapy. And only 5 patients developed UTI and 4 patients reported genital infection. And this is something that it will come again and again in the different talks as well. 29% discontinued due to no benefits. So here you can see the patient flow diagram. So we approached 668 type 2 diabetes patients, and finally we recruited in the 412. And there are a number of reasons, such as, we are a specialized center. We sometimes use patients with type 1 diabetes. I'm not going to recommend that on that protocol for your people, but some of them have got type 1 diabetes. Umar, that might be your patient on weight loss, most probably, not mine. So, and some of them have got no follow-up data visit at all. So look at effectiveness and safety. So weight loss, 1.98 kilogram from a baseline of 87 kilogram. HbA1c reduction, again, what we expect from the even UK data, where I show it's more than 9%, you'll see more than 1% reduction. So 1.1% reduction in HbA1c. Systolic blood pressure about 2.80 millimeter mercury, diastolic blood pressure 2.02 millimeter mercury. Look at the side effects. As I mentioned, 5 UTIs, 5 have got some urinary shortage problems, 11 patients asking about polyuria. Around 40% will have no side effect at all. 5 or 19 patients actually have got hypoglycemia. Most of them are usually we found out on sulfonylurea or insulin. And then 4 patients with genital infections. So generally, what I have experienced in UK data and the ABCD data is pretty much showing the same thing. This is quite an interesting slide, because if you look at those patients where HbA1c was more than 9%, so there were 170 at a baseline, only 23 have HbA1c more than 9% at the end of 6 months. And we were able to increase our proportion of patients with HbA1c less than 7 or between 7 to 8%. So from less than 7, from 61 to 127, we have doubled the proportion of patients. And for 108, we've increased it to 164. So, it does work. And that's the beauty about it. So now I have summarized you the other 3 studies as well. So if you look at HbA1c reduction, our data from Pakistan shows somewhere between 0.85 to 1.3. So 0.85 from South Punjab, they have got smaller or they have got lesser baseline HbA1c. 1.1 from Mid-Am, 1.2 Ahmad, and 1.3 was Mid-Am, and our one was 1.1, and 1.2 was Ahmad. Weight loss 1.98 to 2.81 kilogram ranging. And look at the safety profile, somewhere between 1 to 7% UTIs. 1 to 3% have genital tract infection. Now I've got my own theory about that, but I'll come to that later on. We suspected, I mean, Aamir Saab suspected, and I agree with him completely, that's because we practice gut hygiene, and he will come to that later on as well. But up to 44 to 86% based on different. So our one have shown 44, other studies have shown up to 86% have no side effects. 2 to 29% discontinued due to various reasons. I will quickly go through the Liraglutide. Again, this is a real world evidence across different countries. You're looking at 1 to 1.5% reduction in HbA1c with a weight loss of around 2 to 3 kilograms. And again, in Pakistan, there were so far 3 small case studies, one from Ahan, 68 patients. Again, our one is collaboration between Umar Center, so 100 patients, and we actually look at our treatment satisfaction data as well. And then Yazdi University, around 49 patients. So if you look at our experience, 103 patients, mean age 49, HbA1c 8.72, HbA1c reduction 1.76, 20% achieve HbA1c less than 6.5. Most of them are on 1.2 milligram. That's what we expected. But there are few, 13% on 1.8 milligram, 1% on 0.6 milligram. We found that 55% highly adherent, 41% have got medium adherence. Nausea, as I expected, the most frequent side effect, 48%. While 34% experience no side effect at all, there's a higher dropout rate as compared to, I would say, Dapagliflozin or SGLT2 inhibitors. I would expect that 32%. Various reasons: cost, loss of follow-up, fear of long-term side effects. So here you can see HbA1c reduction 1.76, a fasting glucose reduction of 89, weight of 5.36, systolic blood pressure 12.3, and diastolic blood pressure 5.55. And again, side effect, majority is nausea. 2 patients have got diarrhea, 2 vomiting, 5 nausea and vomiting, 1 nausea and diarrhea. So mostly GI side effect. And look at the effectiveness, domain increase from a baseline 50 to 71. Global satisfaction also increased. Convenience pretty much remains same, showing that it's actually due to the injection. People don't like the injections. So to summarize, HbA1c reduction 0.95 to 1.76%. Yazdi University data is 3 months. Weight loss 1.38 to 5.43 kilogram. And GI side effect more common with nausea ranging from 8 to 34% and up to 34% have no side effect. And there's a dropout rate of 10 to 32%. So to conclude, well-designed real-world studies complement randomized controlled trial, generating data that could not be obtained in a trial setting and confirm the effect of intervention in everyday clinical practice. Real-world evidence confirms that this is replicated in standard clinical practice, despite the greater variety of patients seen in terms of age, body mass index, and comorbidities. An ongoing prospective database and observation studies will generate data on the long-term safety of Liraglutide and Dapagliflozin and are expected to deliver important insight into prescription practice. And I urge all you guys to start collecting your own data. We do need it. You look at India and China, they actually come up with 10,000, 20,000, 30,000 patients data. And we have got a population of now with type 2 diabetes over 3 crore. I cannot see why we cannot together correct easily 40 to 50,000 patients on Dapagliflozin and Dapagliflozin, and we need that. And we are trying to work on the platform of PES, but this is the need of the day because we have to back up what we are practicing is actually effective on our local population data. Thank you very much. I'm open to any questions. So, yep, references.
Thank you, sir, for such a comprehensive talk and good time management. Now the house is open for discussion. Due to limited time, we will be able to take only 2 or 3 questions.
डॉक्टर उमर कहते हैं एंडोक्राइनोलॉजी डायबिटोलॉजिस्ट सर, आपने डेटा बताया कि ये डापा आपने दी है सिर्फ या इसके साथ कॉम्बिनेशन और भी टेबलेट दी है या इंसुलिन के साथ दी है? और दूसरा ये कि सिर्फ ये डायबिटिक पेशेंट का ओबेसिटी था या आम पेशेंट का था?
ओके, सो पहला दूसरे सवाल का मैं पहले जवाब देता हूँ. आपने फ्लो शीट देखी होगी. हमने जो टाइप 1 वाले थे, अच्छा हम स्पेशलाइज्ड सेंटर हैं तो हम तो देते हैं. मैं अभी भी इस प्लेटफॉर्म पे टाइप 1 में देने में मुझसे ज़्यादा है डीके या वो हो जाएगा. सो प्लीज टेक दैट मैसेज के इट्स अ स्पेशलिस्ट लिमिट. सो एंडोक्राइनोलॉजिस्ट उनको दरमियान से रेफर कर दे टाइप 1 को है. टाइप 2 में यस दैट्स अ फैमिली डॉक्टर्स मेडिकल स्पेशलिस्ट, उनको देना भी चाहिए. इट्स अ गुड ड्रग. सो इसमें टाइप 1 नहीं थे. ओबेसिटी के तो मैं वैसे देता भी नहीं हूँ क्योंकि आपका डाटा ओबेसिटी का है बहुत कम है, 0.51 किलोग्राम है. देयर इज सम स्टडी ऑन कैनाग्लिफ्लोजिन नॉट ऑन डापाग्लिफ्लोजिन. उसकी वजह यह है कि आप टाइप 2 डायबिटीज में SGLT2 रिसेप्टर भी ज़्यादा बढ़ जाते हैं, इसलिए आपको ज़्यादा वेट लॉस आता है. नॉर्मल बंदे में ये चीज़ नहीं है। तो इसमें सिर्फ टाइप 2 डायबिटीज पेशेंट्स थे और बाकी ने भी अपने डाटा सिर्फ टाइप 2 डायबिटीज थे। और जो आपका पहला सवाल था कि बाकी दवाइयाँ हैं, देखें ये यूजुअल केल है। इसमें जो हम स्टडी करते हैं ना, उसमें हम ये कोशिश करते हैं कि दवाई एक ही डालें एक टाइम पे, लेकिन साथ स्टैंडर्डाइजेशन चाह रहा होता है तो कई दफा किसी को बाद में आपको दूसरी आनी पड़ती है। ये 6 मंथ का है और आप कोई भी दवाई डालते हैं ना तो आप 6 महीनों तक वेट करते हैं, फिर उसका इफेक्ट देखते हैं। तो वो जो आपका सवाल है कि क्या 2 इकट्ठी डाली गई हैं या 3 इकट्ठी हैं, यूजुअली आप पहले एक डालते हैं और फिर देखते हैं। ये है कि उनसे कुछ जो है वो इंसुलिन पे भी हैं, कुछ जो थे वो दूसरी ड्रग्स पे भी थे। एंड अगेन दे आर अदर डाटा, और वो ज़्यादा डिटेल में होगा SAFE-Pak में, उसमें तो हमने कंपेयर भी किया है बाकी का कि किन किन के साथ क्या क्या इफेक्ट आया।
टाइप 1 डायबिटीज में आपने दिया है तो
मैं तो देता हूँ, लेकिन
आप देते हैं, रिकमेंडेशन देती है सर? क्या आपने आम डॉक्टर के लिए कहा कि वो ना दें?
उसमें क्योंकि डीके हो जाएगा एंड देन यू हैव टू टेल देम, यू हैव टू वेरी वेरी स्पेसिफिक। बेसिकली टाइप 1 में आपको HbA1c इतना इफेक्ट नहीं आएगा, वो ग्लाइसेमिक वेरिएबिलिटी को बेहतर कर देती है। सो सम टाइम जब मैं फंसा हुआ होता हूँ वहां पे मैं दे देता हूँ, नहीं मैं ज्यादा नहीं देता हूँ। अगेन यू हैव टू मेक श्योर कि उनका BMI 27 से ऊपर हो।
कितनी एज ग्रुप को देते हैं टाइप 1 में आप सर?
मैं 18 से ऊपर ही दूंगा, 18 से नीचे देने से
नीचे नहीं देंगे?
अगर मैंने 18 से ऊपर दिया भी तो।
अस्सलाम सर। सर न्याज नाम है मेरा। क्वेश्चन ये जो डेटा कंडक्ट किया आप लोगों ने 4 सेंटर्स का, तो इसमें किस कंपनी का सार्ट यूज़ किया स्पेशली?
सो अगेन ये दरमियान से वो है, देखें सो कंपनियां 2 ही थी तो दोनों की यूज किए गए जब ये आई थी। तो हमारा तो 2018 मैं अपना उसका दरमियान से करके कर सकता हूँ, ठीक है ना। सो उसमें जो है ना, जो हमारे उसमें है वो 2 ही कंपनीज थी। मैं दोनों कंपनियों का नाम नहीं लूंगा, सबको पता है कि कौन सी पहली 2 कंपनीज आई थी, ठीक है ना। सो उन्हीं का दरमियान से किया गया था। उसमें ये नहीं था कि ये एक पर्टिकुलर कंपनी है या वो पर्टिकुलर कंपनी है, आप दरमियान से करके देख लेते हैं।
अच्छा सर, सेकंड इसके साथ ये कि हाइपरटेंशन की वजह से आपने कहा कि HTN को ये 51% रिड्यूस कर रहा है, लेकिन जो डापाग्लाइफोजिन है, जो HTN रिड्यूस है, HTN पे स्पेशली हाइपरटेंसिव पे, हाँ, तो 51% है। लेकिन
नहीं, 51% पेशेंट है जिनको हाइपरटेंशन थी।
सॉरी,
51% पेशेंट थे जिनको हाइपरटेंशन थी।
अच्छा,
बेसलाइन।
हाँ, तो इस पे रिड्यूस
टू 3 मिलीमीटर मर्क्यूरी करता है, वही 2.68 मिलीमीटर मर्क्यूरी।
इसकी जो 38% कुछ स्टडीज आ रही थी, तो क्या वो रियलाइज है या नहीं इस टाइम? इसकी कुछ स्टडीज थी 38% की,
किसकी?
हाइपरटेंशन के हवाले से, डापाग्लाइफोजिन की।
कौन सी वाली? किसकी बात करें? डिक्लेरेटिव के कर रहे हैं या
नहीं, सिंपली जो DM का पेशेंट था टाइप 2 का, उसमें इसकी जो रिड्यूसिंग देखी गई है।
सो डाटा जो है ना वो 3 to 5 मिलीमीटर मर्क्यूरी से ज्यादा का है नहीं। अच्छा, ये डाटा है कि जितना हायर BP होगा, और ये भी कहना का डाटा है, डापा का नहीं है, कि जितना हायर होगा HbA1c, अगर ब्लड प्रेशर आपका 150 से ऊपर होगा तो आपको 1-2 मिलीमीटर एक्स्ट्रा इफेक्ट मिलेगा, और अगर BP उससे कम होगा तो आपको 2-3, लेकिन 2-3 मिलीमीटर से ज्यादा का डाटा नहीं है।
तो ये तमाम SGLT2 का या
ये अक्रॉस द बोर्ड है। सो SGLT2 इज वेरी मच सिमिलर, इट्स डिफरेंट टू से GLP-1 एगोनिस्ट। SGLT2 जो है ना वो ज्यादातर क्रॉस इफेक्ट है, तो उसमें आप थोड़ी बहुत ही तो उसमें आप डिफरेंस देख सकते हो, लेकिन जनरली आप क्रॉस इफेक्ट देखोगे। GLP-1 एगोनिस्ट एक डिफरेंट गेम है ऑल टुगेदर, क्योंकि वो बेस डिपेंड करता है कि क्या एक्जेंटिन बेस देख लें या ह्यूमन GLP-1 बेस देख लें। वो ये भी आपको डिपेंड करेगा क्या शॉर्ट एक्टिंग दे रहे हैं या लॉन्ग एक्टिंग दे रहे हैं। ज्यादा जो कार्डियोवैस्कुलर प्रोटेक्टिव डाटा है वो ह्यूमन बेस्ड GLP-1 हु हैव गॉट अ लॉन्गर एक्टिंग इफेक्ट, उनका असर है। सो इसलिए आप देखें GLP-1 डाटा का जो कार्डियोवैस्कुलर डाटा आया है वो लिराग्लुटाइड का आया है, ह्यूमन बेस्ड GLP-1 लॉन्ग एक्टिंग। दुराग्लुटाइड का आया है, ह्यूमन बेस्ड GLP-1 लॉन्ग एक्टिंग। सेमाग्लुटाइड का आया है, ह्यूमन बेस्ड GLP-1 लॉन्ग एक्टिंग। लिग्जी में या एक्जेंटाइड में नहीं आया, क्योंकि एक्जेंटिन बेस्ड थे और शॉर्ट एक्टिंग थे।
थैंक यू।
Thank you, Umar. I think as the question was raised, and I think it's very pertinent. So what you draw the conclusion was that real world evidence is important. We need that. And I totally endorse that from this platform, a lot of people sitting here, they can join hands with us or ask a PES to support that research. Because ये blood pressure की जो बात की, बाहर कुछ और है, यहाँ हमने कुछ और देखा है। UTIs बाहर कुछ और हैं। So I think very well taken. मेरे 2 question हैं, rather 3. Simple. Dose, what was the dose used? 10 or 5? You said both.
जी हाँ, so 83। अच्छा, अब मैं
I mean, I wanted to see
मैं
5 का क्या हुआ?
मैं आपको चारों की बता देता हूँ।
Right.
जो 4 स्टडी है, हमारी स्टडीज में 83% 10 पे थे,
Right.
about 18% या 17% 5 मिलीग्राम पे थे।
Right. So 10 is what you found.
10 is what हुआ। अच्छा जो अपना मुल्तान वाली है वो भी 400 पेशेंट्स की है, उनके अराउंड अबाउट 70% 10 पे थे, अराउंड 30% 5 मिलीग्राम पे थे। खान वालों ने मेंशन नहीं किया और मीडियम ने भी मेंशन नहीं किया। उनका ये है कि उनका 53% एम्पा था, 48% या 47% डेपा में थे।
So I just wonder whether 5 will be as good or not, but, but one has to see.
So my take on that, आमिर साहब, ये है कि देखें फेज 2 का होल पॉइंट ही यही है कि आपने डाटा वो दरमियान से करना है, ठीक है। सो हमें एविडेंस चाहिए 5 को अप्रूव करने के लिए। उनका बड़ा क्लियर कर लाइसेंस है, वो कहते हैं जी अगर हेपेटिक इंपेयरमेंट है तो 5 मिलीग्राम यूज करें, नहीं तो आपने सब पे 10 मिलीग्राम करना है। टाइप 1 के लिए उन्होंने 5 मिलीग्राम दी हुई है और until unless we are 100% कि जी ये हमारा डाटा है और हम 5 रिकमेंड करेंगे, उसके लिए आप 1000 पेशेंट पे नहीं ये डाटा वो कर सकते। सो आई एम गोइंग टू से देन व्हाई नॉट 10 मिलीग्राम। लोग क्यों 5 मिलीग्राम से या 10 मिलीग्राम से डरते हैं? मैं साइड इफेक्ट में तो कोई खास वो नहीं तुम्हें।
I think that's a lesson, you know, 10 milligram can be used, there's no difference because majority जो आपने real world अपना देखा है, that is showing, you know, 10 milligram maximum. So with that we can take. The other point, sorry. The other point,
थोड़ा सा हमें सब ऐड कर दूं। लिराग्लुटाइड 1.2 मिलीग्राम मोस्टली हम इससे करते हैं कि कॉस्ट का एक फैक्टर है। सीटाग्लिप्टन पे मुझे यही सबसे बड़ा मसला होता है कि 100 मिलीग्राम अगेन और 100 मिलीग्राम में 80% जो है ना वो DP4 जो है ना ब्लॉक होता है, इसलिए उन्होंने 100 मिलीग्राम का किया था। मैं बहुत से देखता हूँ 50 मिलीग्राम देते हैं। 50 मिलीग्राम वो दोस्त पीपल जिनका EGFR 60 से कम हो।
Right.
तो इसलिए 100 मिलीग्राम I think use whatever phase 2 study.
Second simple question. Was there any education given to these people? Was there, you know, that's important, you know, how important was and how frequent was the education given?
So मैं अपनी प्रैक्टिस बताता हूँ, मैं डेफिनेटली उनको UTI और पोलियूरिया का कहता हूँ। अच्छा, and that's very very important क्योंकि आपका मरीज आपके पास आएगा, नहीं तो आपने उसको कह दिया ना, बताया नहीं, तो वो कहेगा कि डॉक्टर ने कैसे दवाई दी है, वो पोलियूरिया को डायबिटीज से लेकर डायबिटीज में रिवर्स हुई है, ऊपर से यूरिन आली करवाएगा, उसमें 3+ आएंगे। कोई बंदा बैठा होगा जो कि मोस्ट प्रोबेबली ENT स्पेशलिस्ट है, उसने तो आपको उसने कहना किस डॉक्टर के पास गए हो। उमर का भी शायद बताता होगा क्योंकि हम दो के दरमियान से
you have,
ठीक है।
so there was education involved.
We actually need to discuss, और आपको शायद वो याद होगा जब ये शुरू में आई थी तो हमने कहा था कि अगर कंपनीज वाले वो वाले एक लीफलेट बना दें उर्दू में कि जी मैकेनिज्म एक्शन क्या है।
That was I was referring to. If it is coming continuously, I think the companies need to do that for the benefit of the patients.
पीछे बैठे हुए हैं कंपनी वाले सारे बैठे हुए हैं।
If you educate them, I think that will work very well. And the third question, very simple again, is Lira में कोई pulse पे change आया था? Did you notice that or pulse पे?
No, नहीं हमने check नहीं किया था, हम check नहीं किया था।
Sorry, it's a last question by Professor Mashur Alam.
I'm Mashur Alam from Karachi. There is an incidence of urinary tract infection in giving DAPA, right? Now, DAPA is to be given over a long period of time, maybe whole lifetime. This urinary tract infection was one-time urinary infection or repeated infections. Was it acute, repeated acute, or was it a chronic?
So मैं आपको इसका दरमियान से करता हूँ, मैं क्योंकि ये काफी आमिर साहब के रिमिट है और मैं उनकी टॉक में जो है ना दाखिल नहीं करना चाहता। UTIs is something that, to be honest, I don't believe कि SGLT2 करती है। And I have I mean मैंने जो भी I have got 2 real world data, one from UK, one from Pakistan. I was part of SAFE-Pak study और आप तीनों में देखेंगे और SAFE-Pak का तो आमिर साहब बताएंगे कि वो तो प्रॉपर हमने UTI को देखा था, उसमें तो ये आए भाई शायद भी नहीं है कि डिपस्टिक है या सिम्टम्स है, आप कह सकते हैं। सो अगेन एक UTI हो या 2 हो, मैं बहुत से लोग पूछते हैं, मैं उनको कहता हूँ हफ्ते के लिए छोड़ दें और फिर दोबारा रीस्टार्ट करें, क्योंकि बेनिफिट इन टर्म्स ऑफ हार्ट और CKD इज ह्यूज। रिकरेंट हो रहे हो तो देन यू कैन से एंड आई आस्क देम कैसे ठीक है बंद कर दें, थोड़ा सा कंट्रीब्यूट डेफिनेटली करेगा, मैं उनको बंद कर देता हूँ। पायरोनेफ्राइटिस का डाटा जो है ना वो अब फेज 3 में भी उन्होंने देखा था, मे भी 1-2 लोगों ने कुछ देखे हो दरमियान में से है, लेकिन हमारे यहाँ मसला ये है कि हमारे यहाँ, एंड अगेन दिस स्टडी रेड बाय आमिर साहब, हमारे यहाँ एसिम्प्टोमेटिक UTI इन टाइप 2 डायबिटीज 9% है। तो अगर मैं 100 लोगों के UTI को मैं यूरिन चेक करूंगा टाइप 2 डायबिटीज जिनको पता भी नहीं उनको इन्फेक्शन है, तो 10 को तो वैसे UTI निकलेगी। वो वी हैव पब्लिश हमारा डाटा है आमिर साहब के साथ, सो इसलिए वो आमिर साहब उस पे आएंगे। यप दैट।
Thank you, sir. So let's move on to our second talk. Our second talk is about EASE trial, and for this I would like to invite Dr. Ibrar Ahmed. He is the current president of Pakistan Endocrine Society. He is a distinguished endocrinologist, assistant professor, and head of department at Lady Reading Hospital, Peshawar. Thank you, sir, for joining us. Over to you now.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. First of all, I'm thankful to Scientific Committee for giving us this opportunity. As already told to you by Dr. Umar, that this portion is of PES initiated research activities. This trial was initiated by us, and it was funded by Pakistan Endocrine Society. So this trial is basically presented to promote the research culture in Pakistan, also on the forum of Pakistan Endocrine Society. So coming to the straight away, as Dr. Umar had elaborately the type of studies, the real world evidence, everything had been told. So this study was basically named as efficacy and safety of EMPA and metformin compared with sitagliptin and metformin in people with diabetes during Ramadan. It was an observational study, and basically it was done because Ramadan is the month of fasting, varies between 12 to 20 hours, and average fasting is 15 hours. We all are suspicious about EMPA. Will this polyuria, will this UTIs will increase? So we have to do this study to look that in our setting, it may cause the same or may be different one. The guidelines say that Ramadan risk categorization is in three risks, and those in 2 and 3 shouldn't fast. So EMPA is a potent and selective SGLT2 inhibitor, as already told. It is effective as monotherapy and as add-on therapy. It had an effect on body weight and systolic blood pressure reduction, and guidelines recommend SGLT2 to be safe during fasting. The concerns among us: number one, that there may be an increase of UTIs, potential for volume depletion, electrolyte imbalance, and ketoacidosis. These are the concerns whenever we start SGLT2 in our settings. So the rationale behind this was that to look at the potential risk that fasting may cause if you add or stop any medication. What adjustments you will do to the patients in Ramadan. This has not been studied in our setup and needs understanding to reduce the adverse effects of diabetes during fasting as patients start taking. So to fill this knowledge gap and to have an experience of SGLT2 in terms of hypoglycemia and dehydration in patients observing fasts. This was the rationale behind this trial. The objective was to study the efficacy and safety of EMPA and comparison with Sita and metformin. It was an observational study. It was done at 11 different sites all over Pakistan, and sampling technique was non-probability purposeful sampling. And we included about 137 patients during this study. The duration was of this Ramadan started 1 month before and end after 1 month. First was that inclusion visit. Patient was included on basis of inclusion criteria. He was properly educated what he will do. Second visit in month of Ramadan, as it was difficult, people was for different sets. So teleconsultation was arranged with them. And third visit within 4 to 6 months after Ramadan. Inclusion criteria was HbA1c between 6.5 to 8.5 with eGFR of 60 ml per minute, and patients consenting to fast during Ramadan. Exclusion was patient on insulin, patient or having contraindication for fasting, and these are the different renal disease, liver disease, unstable angina, hypoglycemic unawareness, and these were the exclusion criteria. These were the different investigators. which involved in this study. A detailed history was taken and clinical examination was done. At the time of first visit, age, height, blood pressure, history of diabetes, gender, BMI, and intention of fat was for fast was taken. BMI and blood pressure measurements were done before and after Ramadan. I already told, the specific education about nutritional and therapeutic management of fasting was done. Following labs like HbA1c, fasting blood sugar, random, fasting lipid profile, renal functions, liver function, and urine RE was done at the start of the study. He was told that dairy card was given, that he should look at the hypoglycemic symptoms and complications. Time from consuming their last meal to the start of hypoglycemia, time from taking their last medication dose to the start of symptoms of hypoglycemia, and was the fast broken between dawn and dusk. Preprandial glucose measurement was to be obtained prior to the evening meal 3 times per week, as due to financial constraints. Safety and tolerability were assessed by reviewing reported adverse events during the study. All adverse events were rated by the study site investigator for intensity, mild or moderate. And patients were contacted by phone 2 weeks after Ramadan and had to start any serious adverse effects. The primary outcome was any hypoglycemic episodes during Ramadan, dehydration episodes, adverse events, and number of days that the patient fasted or had to break the fast due to hypoglycemia. Basically, his efficacy and his safety was the main objective. The changes in HbA1c, changes in weight and BMI, and changes in blood pressure levels after Ramadan and number of days of fasting were noted. So 137 patients were included. Of them, 89 were on metformin and sitagliptin, and metformin and EMPA were of 48 patients. Comparison between the 2 groups were revealed no significant differences. This was females were 66 and male were 71. If you look at this table, age comparable, a bit younger one in metformin EMPA group was included. The male and female were the same. Weight, there was a reduction of about 1.5 kg after Ramadan. BMI was compared and there was reduction in it. HbA1c was reduced, weight, BMI was reduced after Ramadan. This was the comparison before Ramadan, and this was the comparison between the 2 groups. So coming to a single one, applying the paired sample t-test, it shows the RBS from 215 to 203 in metformin and sitagliptin, and 160 to 174. Weight was 76 to 74. BMI was 33 to 31. And here it was also the same. Weight reduction of 2.2 kgs and BMI of 1.5. And there was also reduction of HbA1c. Patient of SGLT2 groups experienced significantly fewer symptomatic hypoglycemic as compared to those of sitagliptin. And there was no significant differences between the studied groups regarding the frequency of patients of volume depletion. So RBS is the same. The hypoglycemic symptoms, which was low in empagliflozin as compared to the sitagliptin, and signs and symptoms of dehydration were comparable. And there was admitted for hypoglycemic were 3 in metformin and sitagliptin group and 1 in. Effects of drugs on urine examination were also observed at the end of study. And there was the ketones remains the same in both groups. Nitrites, which shows the infections, it may be same, and leukocyte esterase in 3 in 1 and 2 in, it showed no significant difference at the end of the study in urine DR. Regarding untoward effects, the diarrhea was 8 episodes were noted, 6 in metformin and sitagliptin and 2 in metformin and EMPA group. Rashes in more in metformin and sitagliptin, hyper and hypoglycemic symptoms more in metformin and sitagliptin group, UTIs more in metformin and sita as compared to EMPA group, and that increased urination was more in the metformin and EMPA group. So these untoward effects were observed during month of Ramadan. So coming to discussion, the study shows that safety and efficacy of SGLT2 in the management of diabetes during Ramadan, volume depletion effects were noted like reduced blood pressure, dehydration, postal dizziness, orthostatic hypotension, syncope, and reduced urine output. So there was comparable symptomatic and documented hypoglycemic episodes between both the groups. If you compare the other comparison of DPP4 with other groups like SUs, so the DPP4 had low incidence of hypoglycemias as compared to the SUs in Ramadan. And this was the study also reported in Arvind et al. If you compare SGLT2 with SUs, in our studies, there was comparable symptomatic between the two groups. If you compare SGLT2 with SUs and observe that patient with SGLT2 experienced significant fewer hypoglycemic symptoms as compared to the SU group. The study which was done by Shao, it shows that diabetic patients, the changes of fasting blood glucose levels treated with SGLT2 were comparable to that was other SUs or metformin or DPP4. The low risk of hypoglycemia with SGLT2 make it an ideal choice for Ramadan. Few episodes, why there were few episodes of dehydration in our study. The episodes of dehydration in currents were few because that blood glucose level were well controlled before Ramadan, as modification of drug therapy was started 6 weeks before Ramadan according to the DAR IGF. This may be the reason behind it. The frequency of volume depletion episode with S ranges from 1.2 to 1.5. The mild osmotic diuresis induced by SGLT2 may be the cause of frequency of some hypovolumic episodes patients can observe during Ramadan. If we come to this limitations, it was a small sample size. Assessment of dehydration was dependent on patients' self-reported symptoms. Because during Ramadan, they cannot move to and fro. So we have to depend on the assessment of dehydration as they were educated before Ramadan. The frequency of SMBGs was also modified to the cost involved. And IDF-DAR recommend checking levels 7 times a day, but it was not practical, feasible due to the cost and the study participants. As it was a small study and assessment of dehydration was dependent of self-reported, there may be some more studies to come which can be more helpful to our. So the use of SGLT2 combined with metformin for diabetic patient during Ramadan fasting is effective, safe, well tolerated with reduced evidence of hypoglycemic events. At the end, we acknowledge PES for providing platform for the study, the funding, and FARMU funded was for only statistical and paper writing. Thank you.
We have few minutes for question answers. If you have any question, please raise your hand.
Because we have excluded that portion before, they were, as I mentioned, that they were in dark risk category 3. They were already excluded from the study. Patient with end organ defect, renal impairment, they were already being, they were not included. There was stable.
Ejection
patient.
fraction was not included in this study.
Ejection fraction with heart failure.
Yeah.
You're talking of heart failure.
Yes.
So people with heart failure were not included in this study.
Okay. Okay.
Thank you very much for a very informative talk. My name is Dr. Aslam, and I'm practicing medicine and diabetology. My query about your study is that we all know that during holy month of Ramadan, symptoms of hypoglycemia, dehydration, orthostatic hypotension, these can be observed even in normal people. So I would like to know that to what an extent the weight reduction, hypoglycemic effects, or dehydration could be attributed to the drugs which are used in your trial. Secondly, don't you think that it would be more advisable and informative if the same group would have been subjected to similar trial, either pre-Ramadan or at least 1 month after Ramadan, and then the studies obtained during these two phases could be compared? Thank you.
Thank you. I will answer the second questions first. The patients were included in study 4 weeks before Ramadan, and they were observed for 1 month after Ramadan, and there were no untoward side effect was noted. Because this is an observation study, we keep the patient going on the previous medications, and we didn't randomize. It was not an RCT trial. Secondly, you are so much correct that the volume depletion already in Ramadan, how can categorize? So in these patients, we educate them that we give them questionnaire that you will be observing this type, dry mouth, this thing. If this is unusual from the previous Ramadan, or you are not experiencing with SGLT2 before Ramadan, and it had been increased during that, you should report to us. So that on that basis, patients were educated regarding that. The exact things were not that we have this. I have already told you that this may be a limitation of this study that we can. So in future, we can go for other randomized controlled trial, so it can be more helpful.
Thank you, sir. Thank you. Now for our third and the final presentation, I would like to invite Dr. Aamir. You all know him very well. He's a consultant endocrinologist and head of Department of Diabetes and Endocrinology Department at Hayatabad Medical Complex, Peshawar. He's a past president of Pakistan Endocrine Society and has received Lifetime Achievement Award for his prestigious efforts in the field of endocrinology. He's going to talk about SAFE-Pak trial. Thank you, sir, for joining us. Over to you.
Bismillahirrahmanirrahim. Thank you very much for a kind introduction. Thank you, my predecessors who have just started this session with real-world evidence and also what the PES is doing. I mean, there has always been an issue that why there isn't enough research of our own patient. And this is the time what we are doing. And I would like to invite, as I've just said earlier, that lots and lots of people need to join our hands with us, give us our data so we can have a larger volume of data and real world evidence in our part of the world. Right, these are my disclosures. I don't think anybody in this hall is not aware of what's the state of diabetes in the world and what's the state in Pakistan. And as you would all know, that recent data from IDF has suggested that we are number 3 in the world, which is certainly not a good news to be a high ranking, but there we are. So diabetes is rampant across the globe, and Pakistan is no exception. That's one part of my opening statement. The other part is that if you look world around, 24% of the Muslims are present in this world overall. So that's about 1/4 of the population of the world is Muslim. That makes about 1.8 billion. Coming back to diabetes, prevalence of diabetes has been increasing, and we've noticed that over the years that when initially the prevalence was around 7% or 8% and then jumped to 9% and then finally to 17% and now to around 20%, this is an ongoing process. We have done lots of things. We need to do a lot of things to improve these numbers coming down. We did our own study, which showed the prevalence of around 17%. So diabetes is an issue. Let's accept that. Let's take another part now. The other part is the large number of patients with diabetes have got a cardiovascular disease. And globally, approximately 1/3 of patients with type 2 diabetes has got a cardiovascular disease. So that's another killing combination. We also know that cardiovascular disease can occur even before the type 2 diabetes is set up. So some process is happening even before the diabetes is set up. And we know that sometimes a microvascular and atherosclerotic disease comes well before diabetes develops, sometimes even 4 or 5 years before the development of diabetes. In our own study, we also found that obesity is a risk. We all know that. But we also found that a normal weight patients have got diabetes. This is peculiar to Southeast Asia and to Pakistan. So even if you're not overweight, you've got a risk. And we published that already in cardiovascular endocrinology. Why it is important? Because the risk of developing diabetes, the risk of heart disease, you die younger, almost 6 years younger if you've got diabetes. And if you've got a cardiovascular disease and diabetes, it's even shorter. So the lifespan is shorter for people with diabetes. It's even shorter for people with diabetes and cardiovascular disease. So this is an important fact. We all know that. It doesn't finish here. I don't know whether Abbas is here or not, but we did another study of finding out the risk factors at the diagnosis of diabetes. And majority of our patients had some sort of around 50 to 60% of patients at the time of diagnosis of diabetes had one or the other risk factor accompanying diabetes, including dyslipidemia, obesity, hypertension. So it doesn't finish, and no wonder that we have got much severe problems than the rest of the world. Now, if you combine diabetes and cardiovascular disease, it is separate, but it's the same. And if you look at the risk factors, they're almost the same, both for diabetes and cardiovascular disease. And if you look at the direct effect of hyperglycemia, they're almost the same. The arterial stiffness, the oxidative stress, the metabolic dysfunction, metabolic syndrome, inflammation, so on and so forth. So if somebody's got a diabetes plus cardiovascular disease, the risk are almost the same, and the effects of hyperglycemia are almost, and the cardiovascular are almost the same. And then there's a progression of renin-angiotensin system, the oxidative stress, all these compensatory mechanisms sets in. So that makes things more complicated for a patient with diabetes and the other risk factor, which I've just alluded to earlier. So why I'm saying all this? Because from our own data and from the literature which is available to us from the West is the EMPA-REG outcome trial. And what did it show? To examine the long-term effects of EMPA versus placebo on top of standard care on CV morbidity and mortality in patients with type 2 diabetes and established cardiovascular disease, just like the population which we are harboring. A lot of diabetes, a lot of cardiovascular disease at the outset with a lot of risk factors. This is what we are harboring. So this was an international study. Obviously, many of you would be knowing about this. And what was the outcome? The outcome was EMPA, in addition to standard of care, reduced the cardiovascular risk and improved the overall survival in adults with type 2 and established cardiovascular disease, including 3-point MACE, cardiovascular death, hospitalization with heart failure, and all-cause mortality. So all was good. So why I'm discussing all this? Because there were some problems with the EMPA-REG trial. And these were the common complications that they saw: the urinary tract infection, genital infection, hypoglycemia, so on and so forth, volume depletion. So this is what was seen in EMPA-REG. So yes, we know that this is a good drug. In the West, it has shown a marvelous results. I don't know why we are bringing this here, but the point is that there are a set of side effects which are worrisome for us. So we thought, let's do something, and Dr. Mashoor Alam raised a question, and I'm going to address that because Umar just alluded to that as well. We thought there's a lot of asymptomatic urinary tract infections associated in Pakistani Muslim type 2 diabetes. So what we did was that in the outset, we had 745 patients. We excluded 200 who had UTI, and we included 545 patients for analysis to see whether there's an asymptomatic urinary tract infection. And this analysis was not done on the basis of simple urine DR. This was done on the basis of urine culture. And we published this already in the BMC in infectious diseases. And what we found was there's around 8% diabetics have asymptomatic urinary tract infection in Pakistani Muslim, culture positive. Remember, culture positive. Female gender has had a high propensity. We also found that 40 to 59 years of age have high proportion in the positive group, and A1C level more than 7 had a high prevalence in group with positive urine culture. So one thing to take message from this initial publication of ours was that there's an asymptomatic UTI already present, culture positive in Pakistani population. We checked about the sensitivity, and I'm not going to go into details about this, but we found obviously a lot of antibiotics were resistant to it, and E. coli was commonest, which is a well-known figure. So we know now that there's a high prevalence of diabetes. 1/4 of population is Muslim, high prevalence of diabetes in Pakistan, high prevalence of heart diseases and diabetics, high prevalence of diabetes and heart disease, CV morbidity and mortality improves, SGLT improves, but with the high risk of UTI. But Pakistani Muslims have got asymptomatic UTI, and whether it's a wet and dry hygiene practice, that does have a same prevalence of urinary tract infection if we use the drug which is in question, which is SGLT2, and which will help our patients or not. And hence, we launched this study called Safety and Efficacy of Dapagliflozin in Pakistani Muslim Population, which from June 19 to August 20. And this was done in Pakistani Muslim type 2 diabetic patients. These were 6 major cities, the investigators, different sites, they were included. So it was a multi-center, open-labeled randomized clinical trial. So we had a key inclusion criteria of type 2 diabetic patients, Muslim patients, both genders, glycosylated between 7 and 10, BMI less than 45, drug naive to AMPA, screening randomization. So it was divided into usual care versus AMPA group. And what we wanted to see was two outcomes, the safety and efficacy. The safety was measured by urinary tract infection, hypoglycemic effects, hypotension, dehydration, and any other results. And the efficacy was measured by glycosylated hemoglobin, fasting blood glucose, and quality of life measurement. This is a patient disposition chart. It's a very busy slide. I don't want you to get confused with this, but what it basically shows is that we had two arms. We initially thought of 170 patients, but one would imagine that in a country like Pakistan, where the follow-up is the most challenging part of the study, it is very difficult to enroll patients, but we managed 121 in AMPA group, and usual care was 115. There were still patients who were lost to follow-up, and finally we had about 170 patients who completed this study. What were the baseline characteristics? If you see the two groups, they almost match. They are almost a reflection of each other. So nothing to choose between the two, but there was some difference that majority of participants in group A were females, which was the AMPA group. They were slightly overweight and they had longer duration of diabetes. So in a way, what we are saying is that in group A, there were more severe patients. We checked the physical activity status of study participants, and there was no difference that how much active they were and whether that will influence the results of the study. That's one group was more physically active and the other wasn't. So we checked the physical activity status, and that is almost matching in both the groups. What were the comorbidities? Again, a reflection from one group to the other. And if you look closely, both groups had hypertension, dyslipidemia, obesity, so on and so forth. So they were almost matching in both the groups. What were the concomitant medication? As you would imagine, the sulfonylureas, biguanides, DPP-4, and insulin were present in both the groups. And also, there were people with the antihypertensive, lipid-lowering drugs, as you would imagine, that standard care which is given. But the important part is that both groups had similar drugs, almost similar drugs in both the arms. We checked this blood pressure with the systolic and diastolic, and we checked the heart rate in the both groups, and it was almost the same. What about the clinical profile, the baseline biochemical profile? Again, if you look closely, in both the groups, they were almost matching. So, and importantly, the fasting glucose and the A1C was almost matching in both the groups. It was around 8.3 on average, and same was about fasting glucose, which was about 150 in both the groups. So apple to apple, both groups were almost matching. One was for AMPA and the other was standard care, and at the discretion of the investigator to increase or decrease the dose as or whatever they find necessary. Because when the patient comes in real life in a trial, you cannot just leave your patient with A1C of 8 or above and not to do any action. So it was at the discretion of the investigator to do whatever they wanted to do in terms of achieving the A1C, what they wanted to for that patients. If you look further at the biochemical profile, nothing much to choose between the two. It was almost matching. So what was the outcome of our studies? The primary outcome of our study was the safety part. I think most of the studies presented earlier by Umar and Ibrar, and then finally SAFE-Pak, which was a longer study and more patients in this, around 209 events were noted. So number of patients reported adverse effects was about 8 in AMPA group and 16 in group B, which was a standard care. There were patients in those 16 who had had hypoglycemia more than once, and that's why the number has gone up instead of in the same patient. Hypoglycemia was recorded more in the usual group compared to AMPA group. Dehydration, almost the same. Hypotension, no comparison except the usual care, there was slightly more. And the positive urine culture was seen in 7% in AMPA group, whereas it was seen 9.9%, slightly higher number in the standard care. And I want you to refer back to our first study, which was asymptomatic UTI. We were seeing about 8 to 9% of asymptomatic UTI anyway in those patients. And I just wonder, that is what is reflected here. But we're going to talk about that in a minute. So there were patients who discontinued the therapy, and the positive fungal infection was present in 2% of patients with standard care. So all in all, what it looked like was pretty good results in terms of pretty safe results in both the groups, but I'm going to excel more on that. So in summary, we had hypoglycemia positive urine culture more in the usual care group. 12 in the usual care group reported hypoglycemia, and there was an association of sulfonylurea insulin with hypoglycemia found insignificant. We particularly look into that, but that was found insignificant in both the groups. In AMPA, there were 6 patients who reported hypoglycemia, but remember, there were still patients in the AMPA group who were on insulin. So you would expect that going to happen. Fungal infection was reported in a very small number of participation, and that's why we alluded that it possibly because the education was done every time the patient were follow up at the 12, 24, and further on weeks. So in summary, we saw positive urine culture more in the usual compared to the intervention arm. What about the secondary outcome? And secondary outcome was glycemic control, weight, blood pressure, and lipid profile. If you look at the A1C, there was a significant mean reduction in both the groups. So as I said, if you are not using EMPA, even then you improve. The outcome still improved. And if you look at the drop in A1C, which was around from baseline to visit 3, which was about 7.4, around 0.9%, which was clinically and statistically significant, it was dropped in both the groups. But what was important was that over the time, there were more patients in EMPA group who achieved less than 7% A1C than the standard group. And at follow-up 2, and again at follow-up 3, there were still more patients who achieved A1C a target of 7%, less than 7% over the time. What about the blood glucose? Target of fasting blood glucose is 100 to 120 over time. And if you again see, there was slightly more patient clinically in the EMPA group at follow-up 2, and the same applies to follow-up 3, but this was statistically not significant. Important part, what about the weight? And there was a drastic, well, major weight loss compared to the standard arm. If you look, it was a minus 1.4 kilo of weight loss in AMPA group compared to standard group. So what we are saying here is that we are achieving the A1C with the benefit of the weight loss when you're using the SGLT2 in our group. And also what we are saying here, the second outcome which we saw was a systolic drop in systolic blood pressure, which was around 5 millimeter in the EMPA group compared to standard arm, because we know that SGLT2 cause osmotic diuresis, and as a result of volume depletion, you're going to see slight drop in blood pressure, which was seen in our group. On a lipid profile, there was some beneficial effect in the mean LDL level from 106 to 97 milligram per deciliter. On effect on liver functions, and Dr. Ali Jawa presented a wonderful talk yesterday regarding a fatty liver, and there are lots of drugs which improve fatty liver, We know the pioglitazone does, and a lot of other. But overall, if you're improving the metabolic control, you're going to see improvement in the liver function, which we saw in both the group, but more so in the AMPA and usual care group, even in both. When you improve the glycemic control, the outcome was favorable. What about the quality of life outcomes? We noticed in both the group, the scores were almost the same. They were almost overlapping each other, which means that people who were on a standard care or people who were on Dapagliflozin, they both scored good on a DM quality of life score 15, which is specific for type 2 diabetes. They scored similar. So there was a satisfaction on the treatment, there was satisfaction on diabetes control. So in conclusion, what we found was Dapagliflozin is a safe drug of choice compared to standard care in Pakistani Muslim population. The same drug is as effective as standard care because the A1C reduction was almost similar in both the groups, but achieves glycemic control with weight loss. In addition, we also found that AMPA had a significant blood pressure lowering effect, especially systolic blood pressure compared to usual group. This is the added benefit, and we so often want to kill two birds with one shot, because if it is dropping blood pressure to our liking, this is what we would like. That's what was seen in our study, and with the safety and efficacy of Pakistani Muslim population, what I initially alluded to, does it reflect the CV benefit for the future? I can't say right now, but what we have seen in AMPA-REG, that there was a clear-cut hospitalization difference, 3-point MACE difference, quality of life, overall morbidity and mortality was improved in AMPA-REG. Whether we can extrapolate that in our population, the answer is yes, but I don't have an evidence. But what we have seen is the drug works very well in our population. We have already presented in PSIM in Karachi in 2019, and we have also presented our this study in Diabetes UK Professional Conference. We've also presented in ACE earlier this part of the year, 2021, and it is almost in the final phase of publication in Diabetes Therapy European Journal. So we are very excited about it. That is one of his study which has been published internationally. And finally, this is our group, and it is not one-man job. This is all the group, proud group that we did this study with. So together we can go far. Thank you very much for your attention.
The house is open for discussion. If you have any question, please raise your hand. Mic didn't.
Can you use the mic, please? Yeah, I think it's for the, it's being recorded, so it's good to have a recording.
Sir, Fawad sir, from sir, एक point of सिर्फ concept करने के लिए, वैसे मैंने multiple time आपके study milestone sir diastolic के बारे में mention किया था. It's only systolic blood pressure which is being targeted.
True.
With your wide experience, do you really think diastolic blood pressure का down the list weight loss जब होगा, so that could also be beneficial with this, which will be which will translate to the long-term effect, as we all know the reduction of anti-hypertensive blood pressures medicines do work there, और वो blood pressure की medicines कम हो जाती. Why not diastolic blood pressure? हालांकि multiple times इसका answer हो चुका है, मेरा concept clear नहीं है अपने लिए.
Yeah, I think you know, it is science, and we've seen what the science says. We've done the experiment, and this is what we saw. Obviously, the systolic is because of the volume depletion, and it is a volume depletion which is causing this. And that's why I think I didn't mention here, we saw slight rise in the urea.
Yeah.
Clinically, we saw, and biochemically, rise in the urea, which didn't settle later on, which is established. In fact, that was one of the observation I didn't mention that here. So because there's osmotic diuresis, you're going to see that the systolic is the more effective, and you know the diastolic is obviously the arterial part, the stiffness part. Probably it doesn't work there. I wonder if you use this drug earlier in the course of the disease, some of the benefits you're going to see probably in the diastolic. So because diastolic is obviously the compressible part, the vascular part, and systolic is the volume and the pump part. So that's what we are seeing. So I don't know the answer to that. What will be in the future, I don't know.
Thank you.
So congratulations, Aamir, for yet another original study. It's very heartwarming to see. Every time I come to Pakistan, I witness this, and I've got two quick questions. First is, PES has done a wonderful job of this scientific medicine. So what are you doing to get the next generation ready for this? Because one day you all will retire, and this mantle needs to be taken by younger generation. So that's the first one. Secondly, your study mentioned Pakistani Muslim population many times. Do you think there is a difference in non-Muslim population, or was it a particular aspect of study that you wanted to?
Right. The second part is easier. So yes, we thought that our theory was that because of the wet hygiene practice, which is mostly done in the Muslim rather than the others. Having said that, strictly speaking, we didn't ask everybody that whether they're practicing that, but we assumed that they are Muslims, and we had a six or seven non-Muslims which were excluded for the same reason. And these were the questions which were raised to us by the reviewers as well, that why Muslims. So we thought, this is why the hygiene practice in the Muslims is different. If you go to Europe, there's no wet hygiene. You struggle there, don't you? You carry a bottle around with you. So that's one part. The first question, I think PES is doing reasonably good job in a way that we are encouraging. And I think one of the encouragement which I think Ibrar mentioned and Said mentioned in his initial interview, that we are giving grants to people who come up with proposals. Young, whoever come with a decent proposal, we give you a grant, and grant for a good research. And we've had grants in PES. So yes, we can get a grant easily being, older, but yes, we're giving to younger people grants, travel grants, and research grants if they come up with a proposal. So this is what we are trying to improve, and to tell you what was very, heartening to see that this time we had about 54 or 55 abstract to submitted to us, and they were very keen, and we were still getting. So which is a good thing. I think the culture is developing, and we need to carry on. So thank you for bringing this question.
Assalamu alaikum, sir. After DAPA, HF, and Emperor, we know that a lot has changed about SGLT2 inhibitors. We are usually being invited at cardio conferences to discuss with them the SGLT2. So my question is that, have you started using SGLT2 in non-diabetic patients with heart failure?
No, we're not that bold. We're not cardiologists. No, we haven't.
We haven't. Okay. No. So that was just my question.
We've got enough of diabetics to be treated.
Okay.
Right.
Well, you said there is asymptomatic urinary tract infection in the population.
Yeah.
And which was reflected in your paper that in the studies.
Yeah.
But could easily be excluded. Those patients who had urinary tract infection could have been excluded from this study.
Right.
So then we would get the effect of DAPA SGLT to find out what was the difference between this category of patient. Number two, question is related to diabetes as such. We have a galaxy of diabetologists, endocrinologists, physicians here. We talk about diabetes coming up, Pakistan population number 3 in the world. Now, and we all trying to do curative work. There are 50 stalls selling medicines, 100 physicians talking about how to treat in the best form. Clearly, we are failing, we are losing, we're fighting a losing battle. Diabetes is going on, and with the entire country working on diabetes is not able to match this increase. Two, it is well, if you go back to the DPPV study in which exercise and weight loss, 58% reduction in the incidence of diabetes. The thing is that it is quite clear that we as a poor nation would not be able to afford cure of diabetes. So many complications, so much drug therapy, so much. We have to concentrate on preventive. Now, I have not found out any paper here or any stall talking about prevention of diabetes. And our salvage lies in prevention of diabetes.
Absolutely.
Rather than this.
You've hit it right on the head,
So
but I'm going to comment on that.
The question is, we attribute this increase in diabetes to lifestyle, which is sedentary, and increased food intake. Okay. Now, how did this thing prevail in our society? Eating much and not doing too much work. How will it be reversed, this social habit? शादी हो तो मंगनी, निकाह और वलीमा, दावत दावत दावत, खाने तक खाना. अच्छा, उसके बाद भी खाना चलता रहता है. अच्छा, फिर बच्चे की पैदा हुई, बर्थडे हुई, खाना, इसको बुलाना, उसको खाना, ये खाना. There are two things we are consuming: oil and sugar. Now, this is the general aspect in खाने की जो है, वो 2 उंगल खाना, तेल ज्यादा होना चाहिए, जब सालन का मजा आता है. तो खाना कहा था कि एक ने कहा कि खाने की सालन की शान बढ़ाए घी, नाम बड़ी बहू का. तो I think we have to concentrate on prevention as much as we are doing on the curative.
I will forget all your comments and questions, so that I want to answer quickly. The first part, we excluded the people with the symptomatic UTI. We excluded them. So that's the answer to your first question. The other study, which was asymptomatic, was random screening of diabetic patients. So that was separate. So that was not a part of this study. That was a random screening with the culture positive. But those who were positive were not included in the study. This is what happened later on. About the prevention part, I would respectfully disagree with you. And the reason I'm saying disagree with you is, as I said, respectfully, diabetes is a double-edged sword. If you don't manage diabetes, you're going to see blind, renal, and heart proliferating. So we have to treat that. You cannot go, yes. So that's why we are doing what we are doing. There are a lot of stalls working on a good management, GLP, SGLT2. So we have to do that. We cannot shy away from that. The second part is why we are not doing on a primary prevention. Inshallah, you will hear probably tomorrow, something about the prevention part. And the reason for that is that unless it comes from the government and the major, there are schools open with no school grounds. There are the societies, the housing societies made with no parks in it. So it's a multi-pronged problem. So what we decided and what Ibrar's vision was, our president, is that we need to involve the government. We hopefully will sign an MOU with the government tomorrow if we are lucky. We've got a representation from the government. And once we sign the MOU, then because we have, and as you've rightly said, we've failed. We have failed in diabetes. That's why the prevalence is high. But what if we have failed now? At least our next generation, our children, should not fail. So we need to invest on our children, and that's what our priority is. And hopefully, we will be working on the school level. In KP, I don't know whether you're aware or not, it is banned, it's done, it's written, it's being, implemented, that no soft drinks in the schools. It's done, it's banned. It's notified. So we're trying to do these legislations, and this is the only way. There's no shortcut. And we will be probably inviting people from the West who have had a good experience of prevention program to our setup to see how we can replicate. Our culture is altogether different. And in the interest of time, I will stop here, and I don't know, you want to? Yeah. True.
Bangladesh is, and Burdam is doing a marvelous job there in Bangladesh. I had met Professor late M.A. Ibrahim when I was a young house staff. Now the thing is, how have they been able to keep themselves low.
Right.
What is the dietary habit? What is the social habit?
I will, inshallah, if I'm living around, I will be showing single nucleotide polymorphism in Pakistani patients, which we have got the data now. So we have seen a genetic part, which we will be, inshallah, it's in the press. Once that is done, so we have seen that genetic part. As I've mentioned, we've already published that even if you're not obese, we are seeing diabetes in Pakistani. So that's where we started single nucleotide polymorphism, and we have got a data of about 230 patients. And we've seen the nucleotide changes. So single gene nucleotide polymorphism, we've seen that. So I'm going to be sharing, inshallah.
One lesson that you have learned from COVID is the mobile phone. On the mobile, you pick up, instead of Gana Bajana, ye wo tune, they gave a message, ke mask pehno, ye karo, wo karo. And I think that has contributed a big deal in reducing it. So once we are trying to talk with the government, we can also suggest to them that on the mobile phone, instead of the
there were a lot of limitations. We've already done that. There was a lot of limitations, but we are working on that part as well. Thank you very much.
And due to shortage of time, we won't be able to take any more questions. Now I would request our worthy panelists for their valuable comments regarding today's session. Dr. Zaman, Sheikh, sir.
Okay, thank you very much. Three great talks by three speakers, great speakers. First by Dr. Umar Yousaf Raja. He mentioned the importance of real-world evidence and real-world studies. Nowadays, trend is changing. Instead of artificial environment, of placebo-controlled, double-blind type studies, which are more expensive, are focused, very expensive. We are entering into the natural environment. Clinical evidence is better than artificial environment. तो आजकल ये ट्रेंड है कि रियल वर्ल्ड एविडेंस पे स्टडी करें, which is cheaper, and surprisingly, results they are almost equal with the double-blind control, placebo-control type studies. And it is nice to see that in Pakistan many real-world studies are being done, and with quite encouraging results. So I salute pharmaceutical company who involve renowned endocrinologists and do regional, local studies rather than following the foreign studies. Some words about DAPA. DAPA is a strange drug for type 1 diabetes, first time, along with insulin. Dapagliflozin not yet approved, only by EMA. DAPA is approved, FDA hasn't approved both. And regarding congestive cardiac failure, first drug DAPA, then came Dapagliflozin. Whether diabetes or not diabetic, heart failure, it is a good drug. So cardiologists say that it is our drug, SGLT2 inhibitor. And nephrologists say, no, it's our drug, because in CKD, it gives very good result, whether there is diabetes or not. Sugar hai ya nahi hai, CKD ko fayda. Sugar hai ya nahi, congestive cardiac failure ko fayda. So it is a strange group of drugs, a novel drug, and luckily we have got SGLT2 inhibitors in Pakistan at very cheap prices. So he mentioned so many studies done in Pakistan, which is very encouraging. Ibrar Ahmed mentioned about a study conducted during Ramadan. अच्छा ये SGLT2 का बहुत गलत फहमियाँ थी कि रमजान में नहीं दे सकते. Initially we used to say कि रमजान में नहीं दे सकते, डिहाइड्रेशन करती है. उसके बाद थोड़ा थोड़ा हिम्मत बढ़ी है, नहीं इफ्तार के टाइम पे दें. अब कहते हैं इट इज क्वाइट सेफ. और आमिर साहब ने तो बता दिया कि ये जो साइड इफेक्ट हैं ये प्लेसिबो से भी कम है SGLT2 इनहिबिटर के. सरप्राइजिंग. So wonderful drugs, new drugs coming in Pakistan, SGLT2 inhibitors and GLP-1 receptor agonist. And luckily we have got 2 weekly GLP-1 receptor agonist available in Pakistan, and we will get more benefit out of these drugs. Thank you very much.
Thank you, sir. Dr. Faisal Masood, sir, your comments, please.
First of all, I will congratulate PES. This is the first time 3 studies has been presented on PES platform, which PES has conducted. Like obviously, Dr. Umar, wonderful talk on Pakistani population with DAPA, and that shows we can talk even abroad, because हमें सबसे बड़ा मसला ये होता है कि हम Western data तो देख रहे होते हैं, but we don't know what are the actual data in our population. That is very important. That is Umar has shown us, and that is wonderful. Like again, Dr. Ibrar, Ramzan की guidelines we follow like all over the world. लेकिन हमें अपनी इन drugs का हमारे अपनी population में रमजान का जो effect है, that fear all has gone. So it means with this class SGLT2. We can safely prescribe in like Dr. Zaman said, जैसे कहा कि CKD, heart failure, and even no hypoglycemia in Ramzan as well. And obviously, last but not the least, Dr. Aamir, when मेरे जैसा आदमी जब भी उनकी तरफ देखता है, तो it gives me inspiration, and it means energy, and that's you can get from Dr. Aamir. And I think जितने भी हम endocrinologist हैं young, मैं young तो नहीं हूँ, but still I feel, लेकिन I think he is an inspiration for all of us, full of energy, and you can learn as much you can, there is no limit. So thank you all of you, and these are the kind words from my side, and I'm grateful PES ने हमें invite किया. Thank you very much.
Thank you, sir. Thank you. With this, we have reached to the end of today's session. At the end, we have shield distribution. For shield distribution, I would like to invite Dr. Usama to come on stage and distribute shield among panelists and speakers. First of all, I would like to invite Dr. Ibrar Ahmed to receive his shield of appreciation. Next, I would request Dr. Aamir to please come on stage and receive his shield. Dr. Umar की वो कह रहे थे receive करिए उन्होंने एक से एक. Now I would request our panelist, Dr. Zaman Sheikh, to come forward to receive his shield of appreciation. Dr. Faisal Masood Qureshi, sir, please come forward. Then we have a list of investigators who have participated in the study of Dapagliflozin in Pakistan. I would call their name. Dr. Sajjad Ali Khan, please come on stage and receive your shield. The next investigator is Dr. Umar Wahab. Please come on stage. The next shield is for Dr. Umar Yousaf Raja. Please stay on stage. The next shield is for Dr. Usama Ishtiaq. Thank you. The last shield is for myself.